So welcome everyone. Firstly, I'd like to acknowledge the traditional owners of the land on which we meet, the Wurundjeri people of the Kulin Nation, and pay my respects to their elders and families past and present. I'm Professor Rod Hicks. I'm the Director of Cancer Imaging, the co-chair of the Neuroendocrine Tumour Service, and the head of the Molecular Imaging and Targeted Therapeutics Laboratory here at the Peter Mac. As you're all aware, Peter Mac is a very proud member of the Victorian Comprehensive Cancer Centre, which is a collaboration of 10 major cancer organisations comprising hospitals to the west, east and central Melbourne, medical research institutes, and Australia's #1 university, the University of Melbourne. Individually, each of these organisations are leaders in their fields and represent a formidable force committed to working together to advance and accelerate cancer research, treatments, prevention and cures. It's with that context I'm really pleased to introduce our guest speaker for today, Professor Eyal Mishani, who oversees the vibrant research and development program at the Hadassah Hebrew University in Jerusalem. If you've ever been to Jerusalem, you'll know it's a wonderfully historic city, but the best view that you could possibly get is from Mount Scopus, from the Hadassah Medical Centre there. It's a wonderful view. He graduated in chemistry from Tel Aviv University with distinction in 1990. Received his PhD in 1994 in the field of organic fluorine chemistry, which is obviously very relevant to today's talk, and then did a postdoctoral fellowship at the Washington University in St. Louis, where he worked with a very good friend of mine who has been very engaged with Peter Mac over the years in the development of our preclinical imaging facility, Tim McCarthy. From mid-2014, Professor Mishani was appointed the head of the R&D division of Hadassah, the general director of the research fund for the Hadassah Medical Organisation, and was also a board member of Hadassah, the technology transfer company of that group. So it's with great pleasure I introduce him and welcome him to Peter Mac and to the VCCC. Thank you.
So thank you for the introduction, and thank you for hosting me here in Peter Mac Cancer Center. And today I'm going to talk about new frontiers in PET-CT molecular imaging, and I will focus on lung, non-small cell lung cancer, targeting the epidermal growth factor receptor, and a little bit about imaging prostate cancer with the derivative of gallium PSMA, with the fluorine-18 PSMA 1007. So I'm going to talk a little bit about nuclear medicine and PET, the layout of Hadassah institution. I'm going to talk about the epidermal growth factor receptor and its role in non-small cell lung cancer, and the development of carbon-11 erlotinib and fluorine-18 erlotinib to visualize the EGFR in non-small cell lung cancer. So nuclear medicine uses radioactively labeled compounds called radiopharmaceutical for the diagnosing and monitoring and treating different pathologies. Radiopharmaceuticals, actually it's a drug which can be either a small organic compound or a peptide, and we attach a radioactive isotope, short-lived isotope, which emits positrons during the decay process of the radioactivity. The radionuclide imaging yields an image of the distribution of radioactivity in vivo following administration to the patient. And there are two ways to produce the radioisotope. One is using the cyclotron, or we can use also generators. For example, we can see here the conventional radioisotope. Gallium-68 is produced by a generator. The rest of the isotope that we can see here are produced by an accelerator, a cyclotron. The half-life of the isotope are varied from 2 minutes of oxygen 15 up to more than 4 days of iodine 1 to 4. The second step is using the radioisotope to label or to tag the organic molecule or the biological molecule, and we can see here the structure of the gold standard of PET, fluorodeoxyglucose, which is labeled with the fluorine 18 via one step, and after hydrolysis and purification, we get the labeled FDG ready for injection. And the third step is injecting the radiopharmaceutical to the patient. What's really unique with the radiopharmaceutical using PET or even SPECT is the high specific activity. We're using a minute amount of, or mass of the molecules in the range of nanomolar, so we are not worried about saturation of the biological system or toxicity. What we need to check is the dosimetry or the dose which the patient is exposed to. And so the flow of PET is production of the isotope, production of the radio tracer, purification and quality control, and then imaging using the dedicated scanner. So what is the characteristic of PET? It's a non-invasive, highly sensitive in the range of nanomolar. It's mostly short-lived radioisotope, as we could see before. We get functional and biochemical information, quantitative imaging, and high resolution. What we can see here in the image is one of our preclinical developed compound for myocardial perfusion imaging. It's labeled with carbon 11 or with fluorine 18. It's quaternary ammonium salts, and it's an image of a rat with our preclinical PET scanner, the Indian. So now I'm going to talk about the role of, I'm going to talk about the layout of Hadassah. We are running 2 cyclotrons, IBA machine, 18 MeV machines, with the new cyclotron, which is here. We are producing fluoride, molecular fluorine, carbon 11, iodine 1 to 4 on the solid target, and copper 64. And with the old cyclotron, we are reducing the conventional radioisotope, as you can see here in the list. We have 2 laboratories. One is the GMP laboratory for clinical use, where we produce FDG, fluoride, flutamethasone for brain and brain imaging, F-DOPA, gallium dotatate, and other radiopharmaceutical. And our basic research project are imaging of TAI2, EGFR with the derivatives of erlotinib, the VEGF, and as I mentioned before, the myocardial perfusion imaging. We have 2 PET scanners, 1 preclinical scanner, and several generators for producing gallium-68. So protein tyrosine kinases, they catalyze the transfer of phosphate in ATP to specific tyrosine residues within protein. They play a crucial role in signal transduction pathways and involving multiple processes. Protein tyrosine kinase malfunction can lead to conditions such as cardiovascular disease and cancer. And most diseases involve PTK dysregulation owing to overexpression of the tyrosine kinase receptor or its ligand, dimerization of the receptors with the related protein, and various mutation in the PTK itself. So protein tyrosine kinases become valid targets to combat cancer, and the EGFR is one member of this family of receptor, which consists of 4 subtypes of the receptor. The HER1, it's the EGFR, HER2, HER3, and HER4. The concentration of HER3 and 4 is relatively low, and that's why most of the researchers are focusing on HER1 and HER2. The EGFR comprises 86 amino acids and 26 exons. It is composed of an extracellular domain, a hydrophobic transmembrane domain, and an intracellular domain with the ATP activity, which contain the tyrosine kinase activity in exons 18 to 24. It exists as an inactive monomer, and after binding of the ligand, there is a dimerization and change in conformation, which makes the receptor active, and this actually starts the process of signal transduction activity. So EGFR is overexpressed in various epithelial cancer, lung, head and neck, colon, and breast, and high EGFR expression is generally associated with invasiveness, drug resistance, and poor prognosis. So the process starts, as I mentioned before, with binding of the ligand to the extracellular binding domain, dimerization of two receptors, change in conformation, activation of the receptor, autophosphorylation, and then tyrosine kinase domain phosphorylation of proteins, which eventually lead to proliferation, angiogenesis, apoptosis, and metastasis. We can target the receptor for therapy either at the extracellular binding domain with the antibodies such as cetuximab. We can target the receptor with the tyrosine kinase inhibitors, which target the inner part of the receptor with the tyrosine kinase inhibitor, the ATP binding sites. And we can see here some examples of tyrosine kinase inhibitors which already have been approved by the FDA: erlotinib, gefitinib, lapatinib, and recently Tagrisso. And each one of these compounds target a different mutation of the receptor in the ATP binding site. So in 2005, it was discovered that the epidermal growth factor receptor has several mutations in the ATP binding site. In general, what we can see in this slide is the mutation which associated with the drug resistance in the upper part, and this is a mutation associated with the sensitivity to tyrosine kinase inhibitor. And the most common mutation are the one in exon 19, 45%. This is a sensitive mutation to treatment with tyrosine kinase inhibitors. The second one is the point mutation in exon 21, again 40 to 45%, and the acquired mutation in exon 20, the T790M. So the question was, can label tyrosine kinase PET tracers guide and monitor treatment in non-small cell lung cancer? So we started to work on labeling tyrosine kinase inhibitor at the beginning or the end of the 90s. We developed several new molecules. Some of them were reversible EGFR tyrosine kinase inhibitors, some were irreversible inhibitor, and we labeled them with the various isotopes, with fluorine 18 on the anilino moiety, with fluorine 18 and carbon 11 on the functional group on the quinazoline moiety. But unfortunately, we worked with the A431 cells, which are the wild type EGFR, and we could visualize tumors. However, we could not prove specific binding by injecting high doses of mass in order to block the binding of the tracer. And then in 2005, we learned about the different mutation, and as you can see here, we start to work on special cell lines which has the IRESA and the approved drug, erlotinib and IRESA, has a higher affinity to this mutation. We can see here the structure of erlotinib, and we can see the structure of gefitinib, and it was found out that only subsets of patients, 10 to 30%, which treated with tyrosine kinase inhibitor, really have a significant benefit from the treatment. So it turned out that in these non-small cell lung cancer patients, they have the mutation in exon 19, 21, and then after treatment with the tyrosine kinase inhibitor, they develop the resistant mutation in exon 20, the T790M. So at present, identification of non-small cell lung cancer patient candidate for first-line treatment with selective tyrosine kinase requires tumor biopsy for verifying the mutational status of EGFR. And the question was, can we use carbon-11 labeled erlotinib in order to identify a patient which will be benefit from treatment with tyrosine kinase inhibitor? So the radiosynthesis of carbon-11 erlotinib was originally published by Memon in 2009. It's a simple synthesis. We start with the des-methyl erlotinib on the functional group at the 7th position of the quinazoline ring. We label it with the carbon-11 methyl iodide, and the yield is relatively good. The synthesis is short, and the radiochemical purity is higher than 97%. And we can see here a preclinical imaging of mice having 4 different types of tumor. The wild type, the QG56 animal model, the HCC827, which is the point mutation, the deletion mutation, the point mutation here, and this is the mice with the acquired mutation. With the FDG, we can visualize the tumor because FDG is not specific. And when we inject carbon-11 erlotinib, as you can see, the only tumor that we could visualize clearly was the one with the deletion mutation in exon 19 and a little bit the point mutation in exon 2021. We can see here the time activity curves of the uptake in the tumor. We can see the highest activity uptake in the exon 19 mutation, the point mutation, and we can see the lower activity in the wild type and also in the acquired mutation. We already did some clinical trials with our collaborators in Bangkok, the oncological hospital, Chulabun Hospital of the Princess, and what you can see here is a 79-year-old female with high FDG avid adenocarcinoma. We can see it on the left side, as you can see here, and this is the injection with the carbon-11 erlotinib, which visualizes clearly the tumor. This is the exon 19 deletion mutation, the sensitive mutation. Another example is with the point mutation with the 62-year-old female. And again, we can see here the tumors with the FDG, and to a lesser extent, we can see the tumor with carbon-11 erlotinib. And when we image the patient which harbor the wild-type mutation, you can see the large tumor with FDG. However, the tumor could not be visualized with carbon-11 erlotinib. So actually, carbon-11 erlotinib can identify the sensitive mutation, the deletion mutation in exon 19. So carbon-11 was successfully employed, and there are several shortcomings with the carbon-11. The half-life of the carbon-11 is 20 minutes. The yield of the labeling is relatively low, so you can make carbon-11 erlotinib and you can inject to 2 or 3 patients, not more, and you cannot distribute carbon-11 erlotinib to other hospitals. So actually the impact or the clinical impact of carbon-11 erlotinib is relatively low. And therefore we were very motivated to try to develop a derivative of carbon-11 erlotinib, knowing that if we look at the chemical structure of erlotinib, we knew that this part of the quinazoline ring is point to the exit of the binding pocket. So we hypothesize that if we will replace here one methyl small group with a larger group of fluoroethyl, we will not change the characteristic of the compound, or we are not going to change the affinity of the compound to the binding site. And what we did here, we again started with the des-methyl erlotinib. We reacted it with fluoroethyl tosylate, and we made the derivative, the 6-O-fluoroethyl erlotinib. And what you can see here is the binding affinity and the comparison with the erlotinib. We can see the results here. The wild type, the binding affinity is moderate, as you can see, and similar to erlotinib and fluoroethyl erlotinib. The binding affinity to the activated mutation, the deletion mutation, which is responsive to treatment with tyrosine kinase inhibitor, is very low and similar to fluoroethyl erlotinib and erlotinib. The point mutation, the affinity is a little bit lower of both compounds, and for the acquired mutation is much lower, but surprisingly is much better than the wild type. So it is clear that both compound, erlotinib and fluoroethyl erlotinib, have a similar binding affinity to the different types of the receptor, the different mutations. So encouraged by these results, we also develop an automated synthesis of fluoroethyl erlotinib. We start with the ditosylate here. We label this synthon, and then we reacted it with the des-methyl. The total synthesis time is almost 2 hours, including purification and formulation. We get a relatively high amount of activity at the end of the synthesis with moderate yield, and the radiochemical purity was very high. And the next step was to try to do a similar experiment with mice with 3 different types of tumor. Again, the wild type, the deletion mutation, and the point mutation. And what we can see here, FDG, we can visualize the tumors. With fluoroethyl erlotinib, we could visualize mainly the deletion mutation in exon 19. And again, if we compare the time activity curves, we can see here the results with the fluoroethyl erlotinib. The highest activity uptake was in the deletion mutation, which is more than double than in the wild type or the deletion mutation. And this time, when we block the binding of fluoroethyl erlotinib with erlotinib, and we can see that the activity uptake is decreased by more than 50%, meaning that we have more than 50% specific binding, and the pharmacokinetics of both compounds look pretty similarly. So the future plan, we started now to do the toxicity test with the fluoroethyl erlotinib, which is partial toxicity. We are not doing the full toxicity test. And we hope to start phase 1 clinical trials in 12 healthy volunteers early next year. So to summarize, only non-small cell lung cancer patients whose tumor harbor activating mutation, either the deletion mutation or the point mutation, in the TK domain of the EGFR are candidate for first-line treatment with tyrosine kinase inhibitors. Human and animal studies indicate that carbon-11 erlotinib can differentiate between the erlotinib-sensitive non-small cell lung cancer from the insensitive or resistant mutation. Preliminary results indicate that fluorine-18 erlotinib holds similar potential to carbon-11 erlotinib, and this approach can circumvent the need for invasive tumor biopsies and facilitate patient stratification prior to tyrosine kinase therapy. So to finalize, I'm going to show you a new derivative of, and I know that you are doing a lot of patients with gallium-68 PSMA, so I would like to discuss with you a new approach to image prostate cancer patients with the fluorine-18 PSMA. It's a new derivative which was developed by the group in Heidelberg, and I will show you the structure in few slides. So, PET tracers for staging and follow-up of prostate cancer, we started with labeling carbon-11 and fluorine-18 acetate, and also with carbon-11 and fluorine-18 choline. We started it in the late 90s, and both compounds work very well. We can see here a patient with bone and lymph node metastasis, and what we see, this is, by the way, a slide courtesy of Professor Einat Eben-Sapir from Tel Aviv, Soratsky Medical Center. And what we can see here on the left side is the metastasis in the bone, and what we can see here is the metastasis in the lymph node. So both compound choline and the acetate worked very well. However, again, the half-life of carbon-11 relatively slow, relatively short, and the clinical impact of these compounds labeled with carbon-11 is not sufficient, and therefore people were looking for derivative. Fluorine-18 choline also worked for a while, but then a few years ago it was the discovery of gallium PSMA. So prostate-specific membrane antigen is a transmembrane protein with significantly elevated expression in prostate cancer cells compared to benign prostatic tissue. It is a low molecular weight ligand, and what we usually do, we bind to the binding area the gallium with a chelator, and then we purify the compound and inject it into the patient. So, what is the indication of gallium PSMA PET-CT? Biochemical failure after defined therapy for prostate cancer, staging of patients with high-risk prostate cancer, monitoring response, assessment of suitability of radiotherapy with lutetium-177 PSMA, and follow-up. And we always need to remember that not all prostate cancers show increased uptake with the gallium PSMA, so there is always room for using other compounds such as fluorocholine or carbon-11 choline or acetate. And you can see here an example, and I know that you are doing a lot of patients here for sometimes more than 3 years with gallium-68 PSMA. But again, this is a courtesy of Professor Einat Eben-Sapir, and what we can see here is gallium PSMA uptake in the primary tumor, and we can see also uptake in the bone marrow in the right side of the slide, and also in the bone. And of course, none of these metastases were visualized by CT. So what are the drawbacks of gallium-68 PSMA? First, the production quantities. What we are doing, we are using generators. We can milk out of the generator something like 40 millicurie, and then after synthesis and purification, we get roughly 30 millicurie, which is sufficient to study 3 patients, and especially when you would like to transfer the compound to other hospitals, you remain with maybe 1 dose or at the maximum 2 doses. The energy of the positron, the kinetic energy of the positron, which is emitted from the gallium, is relatively high, and therefore the theoretical resolution obtained with gallium is less than the one that we can get with fluorine-18. And the half-life, of course, of gallium-68 is 68 minutes, and it's not sufficient to distribute it to other hospitals. And therefore, the group in Heidelberg, they developed a very promising derivative. What we see here is the structure of the widely used gallium 68 PSMA. We can see in the I marked it with the blue color, the pharmacophore. This is the part of the molecule which actually bind to the protein. This is the functional linker, and this is the radio-labeled bearing moiety. This is actually the chelator which chelates the gallium. What we can see here, it's a similar pharmacophore here with the blue. This is the linker, and we label the molecule with fluorine 18 on this moiety. And we can see here several examples of using fluorine 18, and all these papers were published just recently. We started to make fluorine 18 PSMA 1007 about 3 months ago with big success in the clinics. What we can see here is a PET-CT of a patient with prostate cancer 1 hour after injection of fluorine 18 PSMA 1007, and we can see the tumor which was clearly visualized either on the PET-CT and also in the emission. And again, this is axial view. Another example of, or 2 examples of a 72-year-old patient, PSA 15 nanogram per ml, diagnosed with Gleason 9 prostate cancer, and the patient presented with a large tumor mass in the prostate gland, as we can see from the images here. And lastly, another publication from a few months ago, again with the fluorine 18 PSMA 1007 intensity projection PET-CT in a patient with biochemical recurrence after postectomy. And what you can see here, the arrows mark the lesion or the tumor in this patient. So to summarize, fluorine 18 PSMA, by the way, we can make, if with the gallium PSMA, we can make per batch something like 30 millicurie at the most. With the fluorine 18 PSMA, we can make more than 1.5 curie per batch. So we can distribute it, and we can use it for more than 10 patients or 12 patients per batch. So fluorine 18 PSMA performs at least comparably to gallium PSMA, and the advantages are the longer half-life, the high yield, the lower energy, and the low urinary extraction, and the high production quantities. So, as we could see from the 2 examples with the non-small cell lung cancer and also with the prostate cancer, we can say that the basic of positron emission tomography or nuclear molecular imaging is the type of molecules that we are using, and the development of many tracers in the last few years, either for oncology or cardiology or neurology, really open up new avenues for molecular imaging in patients in the clinics. And the examples with PSMA and erlotinib really indicate the future of positron emission tomography in the clinic. And lastly, I would like to thank the group at the cyclotron of Hadassah, and I would like to thank you for your attention and time.